Good morning, everyone. Uh, Today's lecture is going to be on periodontal flap. Now, you must have heard about flap surgery. So what is a flap surgery? A flap surgery is a surgery where we are raising a flap, a periodontal flap. We are raising a section of the gingiva, that is, which consists of the epithelium and the connective tissue. Now, why do you want to raise this flap? You want to raise this flap so that you have access to the underlying root surface and the bone. So basically, we are going to discuss about what is a flap today, what are the various designs in flap, what are the incisions that we usually give when we do flap surgery. Now, flap is nothing but it's a section of the gingiva and or mucosa which is surgically separated from the underlying tissues so as to provide visibility and access to the bone and root surface. So that is a basic idea of a flap. Right? Now, you have different types of flaps. So how do you classify these flaps? You can classify one based on bone exposure after flap reflection. Now, if the bone is exposed or the bone is not exposed. So that is one classification. Second is where you finally place the flap and suture after your procedure. So based on placement of the flap after surgery. Third is how you manage the interdental pad flap. We'll go one by one. Now, based on bone exposure after flap. Now, when you reflect the flap, based on the thickness of the flap, you can classify the flap into two. One is called as a mucoperiostal flap or the full thickness flap. And the other second type of flap is known as the partial thickness flap or otherwise known as the mucosal flap. Now, whenever you need exposure of the underlying bone, what you do is you need a full thickness flap. So you're reflecting the gingiva along with the underlying periosteum. So you have three components there. You have the epithelium, then you have the underlying connective tissue, and then the periosteum. If all these three layers are being reflected, it is called as a full thickness flap. While now this full thickness flap you usually elevate using your periosteal elevator. Now you can reflect another type of flap. That is, you are reflecting only the epithelium and part of the connective tissue. The rest of the connective tissue and the periosteum remain attached to the bone. This type of flap is called a split. You are actually splitting the gingiva, you are splitting the mucosa into two. And this is usually done like probably when you're doing a crown lengthening, you want an apically displaced flap. Some other than root coverage procedures. So these are some of the where you need partial thickness flap, right? So these are the two ways by which you can classify flaps. Classify the flaps based on whether the bone is exposed or the bone is not exposed. So in a full thickness bone, the underlying bone is exposed. In a partial thickness flap, the underlying bone is not exposed. Only the epithelium and part of the connective tissue is being exposed. The rest of the connective tissue and the periosteum remain attached to the bone. Now, the next classification is based on the placement of the flap after surgery. You can do a flap surgery procedure and then return the flap to its original position and suture it. Or you can displace the flap either coronally, laterally, or apically. Okay. So when you place it in its original position, it is an undisplaced flap. When you are displacing the flap to laterally, apically, or coronally, it became a displaced flap. Depending upon which location you are displacing, you can name the flap. Then third is how you manage the internal papilla. Now, when you are doing routinely doing a flap surgery, you put an incision on the labial aspect of the gingiva and then on the lingual aspect of the gingiva. So when you just consider one papilla, maybe the papilla in relation to the central incisors. Okay. If you are doing if you want to reflect that area, so the labial aspect you are putting an incision. In the lingual aspect also you are putting incision, and then you are reflecting the flap. So basically, what happens there is you are splitting the gingiva into two. Gingiva split into the labial and the lingual half. But in certain conditions, especially in conditions where the spacing between the tooth, where in the anterior aesthetic zone, you want to the interdental area, the flap has to be full covered, you can design the flap in such a way that you can incorporate the entire papilla either on the buccal flap or on the palatal. That is called as papilla preservation flap. Now we'll just look into what is this flap preservation. Now in a normal conventional flap, this is what we do. Now, suppose this aspect is the labial aspect and this aspect is the lingual or the palatal aspect. Now you put clavicular incisions all around the tooth. So you put incisions all around the tooth. And this is the internal papilla. In relation to the crest of the papilla, you put a horizontal incision like that. So here also you put a horizontal incision. Here also you put an horizontal incision. So basically what you do is you reflect one half into this labial aspect and the second aspect into this lingual or the palatal aspect. So this half, this part goes to the labial aspect. This part comes here. Okay. And this part comes down. This part. And then after doing all the procedures, you bring it back and close it back. This is called as the conventional flap. You are just splitting the papilla. Now what do you do in a papilla preservation flap? Now in a papilla preservation flap, you can see what is happening here. Now here, what you do is similar to the other flap, you put clavicular incisions all around the tooth. So it is all around the tooth. And then instead of you putting a cross or horizontal incision here, you can put an incision, a semi-lunar incision like this, semi-lunar incision like this, either on the labial aspect or you can do it in the palatal aspect or the lingual aspect. Now, when you reflect this papilla goes into the palatal aspect, and this papilla here, this goes into the labial aspect. So this is done whenever there is a lot of spacing between the two. So only when there is good amount of spacing between the two, do this, because the entire papilla has to be incorporated buccally or lingually. If it is too thin, the two goes together, there is always a chance that this papilla will tear. So you don't do it. And you do it especially in anteriors. So if you have a defect here and if you place a bone graft or things like that, this whole soft tissue will cover the entire interdental area. That is the basic idea of this papilla preservation flap. So then, how do you design a flap? Before doing a flap surgery, you have to look at the clinical findings. You have to look at the radiographic findings. You have to look at all the different aspects of systemic and other aspects of the patient. And then before the procedure itself, you have to plan the entire flap procedure. What type of flap, whether you are doing a full thickness flap or if you are doing a partial thickness flap, whether you are coronally advancing the flap or if you are placing it there and there, whether you are doing anything to the bone or thing is going to be you have to plan it for doing the procedure. Now, for doing flap surgery, basically you need to put incisions. Now, these are integral part of a flap surgery. And how do you classify incisions? You classify incisions into one is the horizontal incisions, and you have the vertical incisions, or otherwise known as oblique incisions. What is a horizontal incision? The horizontal incisions you have mainly three types. Certain two, but three types. You have the internal bevel incision, the clavicular incision, and the interdental incisions. Now, what is an internal bevel incision? The internal bevel incision starts at a margin from the gingival margin, and it's aimed at the bone crest. And this internal bevel incision is also known as the first incision or a reverse bevel incision. And this type of incision is basic to most of the periodontal flap procedures. And it is made with a number 11 or a 15 blade. Now, this is an internal bevel incision. Now, look at this. This is made from the crest of the gingiva to, crest of the gingiva to this crest of the bone, right? The gingival margin to the crest of the bone. So what you do is when you do put an incision like this and reflect this, and after putting the second incision here, this triangular part of tissue, now this forms a pocket lining. So basically you want to remove this pocket lining. That is the basic idea of doing this internal incision. This is almost at 15 degree, 15 degree to the long axis of the tooth. We do this internal bevel incision. Now this you can see. Now when you're doing a cordon flap surgery, you can start from either the midline or from the most distal aspect, and you do it with this is an incision. So this should have started from the look at the incision. It is an incision just like this. It's about 0.5 millimeter from the gingival margin, and it's directed between the base of the pocket and the crest of the bone. That is the basic idea of doing this incision. Now suppose if you have a deep pocket of 4 millimeter here, okay, and if you want to completely remove the pocket, you will be putting an incision somewhere here and doing an anti-displacement. So it will cause a lot of recession in this area. So by doing this procedure, even if the pocket is 6 millimeter also, this will go inside through the thickness of the gingiva 6 millimeter down, and it will remove only this soft tissue lining. So that is the basic idea of doing or rationale of doing this internal bevel incision. So if you carry it like this, then you carry it down like this, like this, like this, you come like this. So that is the internal bevel incision. Objective, as I told before, it removes the pocket lining. It conserves the relatively uninvolved outer surface. So if you are completely remove the pocket, the whole of the gingiva is doing like a gingivectomy, and you will remove the whole of the gingiva. It becomes totally anesthetic, lot of recession results. And then it produces a sharp, thin flat margin, so that that margin gets closely adapted to the bone tooth junction. So these are the three objectives of an internal bevel incision. Now, second incision is called as a clavicular incision. It is otherwise called as a second incision. It is otherwise called as the sulcular incision. You just take the blade and go all around through the sulcus. So that is it. So this internal bevel incision, along with your sulcular incision, that will result in a V-shaped tissue being detached. Okay, and this tissue contains the whole of the granulation tissue, and that is the basic look. You have first put an internal bevel, first put an internal bevel incision like this here, and then you put an clavicular incision like this. So this V-shaped area. This pear-shaped area means that is where the whole of the inflammatory or disease tissue resides. So here, this you put the internal bevel like this here. Now you are putting the clavicular. So this you will get a V-shaped band of tissue there. That is what you're going to find. That is a basic idea of giving the second incision. This third incision is otherwise called as interdental incision. Now these the second incision does not, even the first incision does not go interdentally. So, so after the internal bevel incision is being done, what you can do after the clavicular incision is being done, you just reflect that part of the gingiva, and then through interdentally you place the Orban's knife. Orban's is a spear-shaped gingival knife to go in from the labial aspect and then put it from the palatal aspect also. The whole of the interdental area, that V-shape, that tissue over there will come off. That is the basic idea of this interdental incision. So when you do all these three types of incision, the entire pocket lining around the whole of the tooth is being removed. Yeah. Then this is not done on the labial or the lingual aspect. This is done in the interdental aspect. Yeah. Now you have done the clavicular incision, like this is a clavicular incision. You would have done the sulcular incision, and now you reflect. You have a petrosal this being reflected, and when you reflect like this, you get this. So, and here is where you insert your interdental knife into this interdental areas. Okay. Now this whole of the tissue you can remove. That is the basic idea. These three incisions help in removing gingiva around the tooth. Okay, and then the whole of the tissue is removed using a curette or using a U15 bar 30 scaler. That is a heavy sickle scaler that we use. And after that V-band tissue is removed, all the granulation tissue can be removed. You can visualize the root surface thoroughly. All calculus, all deposits that are present on the root surface, you remove it, and then you can switch. So that is the basic procedure of doing a flap surgery. Now, when you are giving only horizontal incisions without any vertical incisions, such a flap, it looks like an envelope. That is known as an envelope flap. So, a flap which is being elevated only by means of horizontal incision without any vertical incision is known as an envelope. Now, in certain conditions, you may need more of exposure of the bone. Sometimes you don't need to. Sometimes the disease may be localized to one or two tooths where the entire whole quadrant may not be needed to be exposed. So, in such conditions, you may put vertical incisions. Now, vertical incisions are incisions that is put almost along the line angle of the tooth, along the long axis of the tooth. Okay. Sometimes you need to apically displace the flap, laterally displace the flap. All these cases, you make vertical incisions can be given on either side of the horizontal incision, or maybe for access you may be only in the mesial aspect, not doing the distal aspect of the flap. If you can do, sometimes you do on both aspects of the flap also. But there are certain precautions that need to be taken when you do a vertical incision. Now, what are the precautions? Now, look, when you are doing an incision like this, if you have a papilla, you should not just split the papilla like this. Splitting the papilla is not at all good like this. Okay, this will result in the recession. So, what you can do is either you can now this is the area where you are reflecting the flap. So you can put an incision like this. You include this one. This is what they do. Include this one. Or suppose you put the incision like this and exclude this one. So that is how you have to put the incisions. Now again, you should not on this part of the tooth where that's more convex. You should not put an incision because because this whole aspect is the most common aspect. The roots may be prominent, the bone may be very thin, and the flap probably also is very thin in that area. And when you suture that area, there is always a chance that precision will occur. So again, you go to line angles. So you should not split the fibula, and you should not put an incision on the most convex aspect of the tooth. Okay. That is also two things that you should know. And another aspect when you give vertical incisions is vertical incision should be given in such a way that the base is wider. Okay, the base is wider because when the base is wider, you may have more of blood supply to that left. So that is the basic idea. Now, regarding sutures, now after flap surgery, basically you have to do a suturing. And, I think this topic suturing is more taken for you during the oral surgery in your oral surgery classes. I'll just give you a basic idea of that. You can classify these suturing materials into resorbable and non-resorbable. Resorbable is getting absorbed. Non-resorbable are they're not absorbed. You have to recall the patient after 1 week or 10 days, and then you have to remove the suture. You have number of material that is available, but the commonly used material is silk. Braided silk is the most commonly used material. 30 braided silk is the material that we usually use for doing flap surgery. But depending upon other types of surgeries, microsurgery or procedure surgery, probably you may do a 30, 20, 50, 60, especially if you're using microsurgery or loops or something. Again, you may need finer materials and finer suturing techniques. So again, a lot of synthetic materials are also available in the market, like polyglycolic acid, polyglycapron, polyglyconate. All these are synthetic materials that are available in the market. Now, another thing that you should always remember is where you should take a bite when you do a suture. Now, when you imagine that you have reflected this whole area of flap, and now you want to suture. Now, what is this? You should consider this fibula as a triangle. Okay, and then just beneath this base, the center aspect, just perpendicular, in line angle with this tip of the fibula. That is where you should take the bite. So that to take a bite here, there is always a chance that it will it will tear the flap. That is the basic idea. Now, there are different types of suturing. It is very difficult to explain a suturing technique through a lecture. But what you basically do is you go back to your text. You make sure that you understand this suturing technique. This is a common suturing technique that we apply immediately after extraction. So we do you take a on the buccal aspect, you take a bite, and then in the lingual flap, from the lingual aspect, you take it. Just straight away you take it out, and then the suture is called as a simple suture. But a common suture that we do in periodontics is a figure of 8 suture. The first bite is similar to that of the simple loop suture, that is from the buccal you take a right. But instead of taking a bite from the lingual aspect of the lingual flap, you take it from the palatal aspect, from the outer aspect. So both these are from the outer aspect. Then you tie it. It's known as a figure of 8 suture. And these are sling sutures. So all these I'm not going to explain this. Basically, you have to go to a textbook, and preferably you have to practice this in models for you to understand different types of sutures. So these are things what we discussed here are basic things for doing a flap surgery. Like what are the different types of flap? How do you classify flap? How do you classify incisions? What are the suturing materials that are involved? Hope it was so informative for you.